as a practicing clinician, we have to kind of come up with the idea of what's the best treatment for an individual patient. And in doing so, we try to make the determination. We look at their clinical symptomatology, how they presented. We look at their MRIs, and we try to make a determination, how's this patient going to do in the long term? Is this somebody who I'm very worried about, who's going to have a very active, progressive course from the get-go? Or is this somebody who looks more typical of a mild to moderate patient with, maybe some element of disease activity, but not somebody I'm really worried about? So we make those determinations right up front. And with that, we then factor in what are the patient's concerns, lifestyle issues. They may be thinking about a family at some point in the future. There may be, issues related to their job, side effect profile, what kind of day-to-day experience are they going to have to deal with? Are they going to remember to take the medications? All these things. So that you got that piece of it. You got my piece, which is the piece called I'm worried about you or I'm not. You also have the insurance piece that comes into that conversation that says, well, we're not going to let you do any of those. But at the end of the day, we try and factor in all of that and make the determination what's going to be the right treatment for this individual patient, with the idea that we may have to change as we go. That's always a possibility.
When I think about the disease-modifying therapies for MS, I actually put them into three categories. I have the needle injectables, the interferon betas, and glatiramer acetate. I have the three orals, and then I have the infused monoclonals. So if we focus just on the orals and the monoclonals with regard to adherence and side effects, certainly the orals gave you the option of not needing to do a needle injection, and that's a quality of life issue. It's much easier to take a pill or a capsule than to inject yourself. Of course, this puts the onus on taking the medication at home, but certainly you lose the need to inject, and I think that that's a positive. When I look at the intravenous infusible, the monoclonals are the high efficacy agents. Even if they've not been compared head to head, they have high efficacy. As a group, they have greater efficacy than the orals, but they may carry somewhat greater risks. And two of the three monoclonals certainly have a REMS program in place that you need to follow. The thing about the infusible monoclonals is you need to go to an infusion center. You know there's adherence. You know the patient is taking the medication. There's absolutely no issue in that regard. Every DMT for MS has slightly different side effects and adverse effects, and so you need to bore down to the individual. What are their comorbid issues? How do they view a treatment? What are they willing to tolerate or not? But I think the big differences between the orals and the IVs are in the efficacy and in the ease of taking it, and absolutely guaranteed adherence when you need to go to an infusion room.
So all of the approved agents were efficacious. If you look at the numbers, they'll give you what percentage reduction it was in annualized relapse rate. And it could be anywhere from 20s to 30s, 50s, 60s. You can't compare them. It's a fundamental error to try and compare the results of one clinical trial to another clinical trial. And so and this happens with marketing, but the only way you could say you're this percentage better than somebody else is if you're in the same study. And even if you design two different studies identically, you still can't compare them, because every study is a universe unto itself and unique. And there's always factors there that you can't control for, no matter how hard you try, that can alter the results. So if you want to know one drug's better than another, look at them head to head. And as I mentioned earlier, we don't have that kind of data for our most effective agents, and almost surely never will, because they're actually long, complicated studies. Because if you're both very effective, then it takes a long time and a lot of patients to show a difference between them.